Sumit, you can go ahead, please.
Good evening and good morning to all eminent faculty members, participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Samir Parekh, all discussants and participants to this virtual symposium on monoclonal B-cell lymphocytosis, risk of disease progression to CLL and other clinical consequences. Before we commence the proceedings, I would like to welcome and introduce the host and the convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a dynamic and passionate hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you so much, Mr. Sumit Madan. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from the rest part of the world. Today, our guest speaker for the day is Dr. Samir Parekh from Minnesota, USA. He's going to lecture us today on monoclonal B-cell lymphocytosis, the risk of disease progression to CLL and other clinical consequences. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and the team Zydus, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Samir Parekh from Mayo Clinic, Rochester, USA, and all our discussants who are themselves eminent hematologists and medical oncologists, and you participants for sparing your Saturday evening, morning, and afternoon. Tomorrow, that is Sunday, 18 June, we have an update on Hodgkin's lymphoma from 11:30 a.m. onwards by our guest speaker, Dr. Kripa Bajaj from Cancer Hospital and Research Institute, Hyderabad. Let me introduce our discussants for the day, here displayed in alphabetical order. To start with, we have Dr. A.R. Jaswinthini from Yashoda Super Specialty Hospitals, Hyderabad, Dr. Aniket Mohite from Jahangir Hospital, Pune, Dr. Ayan Bhattacharya from Kuch Behar, West Bengal, Group Captain Dr. Harshit Khurana from AFMC, Pune, Surgeon Commander Dr. Kaushik M.R. from INHS Aswini Kolaba, Mumbai, Dr. Mahesh Mandolkar from Dinanath Mangeshkar Hospital, Pune, Dr. Navid Tamboli from Dinanath Mangeshkar Hospital, Pune, Dr. Ranjit Matthew Varghese from Command Hospital, Pune, Colonel Dr. S. Venkatesan from AFMC, Pune, Dr. Samir Malinkri from Dinanath Mangeshkar Hospital, Pune, Dr. Sandeep Bartake from Bharati Vidyapit Medical College, Pune, Dr. Saswata Saha from Tata Memorial Center, Parel, Mumbai, Dr. Sweta Lunkad from Avinash Cancer Clinic, Pune, and Dr. Yi Mon Thant from Yangon, Myanmar. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Samir Parekh from Minnesota, USA. Dr. Samir Parekh is Associate Professor of Medicine, Assistant Professor of Oncology at Division of Hematology, Department of Internal Medicine at Mayo Clinic in Rochester, Minnesota, USA. He joined the staff of Mayo Clinic in 2014 and holds the academic rank of Associate Professor of Medicine and Assistant Professor of Oncology at Mayo Clinic College of Medicine and Science. He currently serves as the chair of the CLL disease team at the Mayo Clinic Comprehensive Cancer Center. He earned his Bachelor degree of Medicine and Surgery at the University of Mumbai from St. G.S. Medical College, Mumbai, India. He then completed his residency at St. Francis Hospital at University of Illinois at Chicago, and a fellowship in leukemia at University of Texas at MD Anderson Cancer Center in Austin. He subsequently completed his hematology oncology fellowship at Mayo Clinic School of Graduate Medical Education in Rochester, Minnesota. His research focuses on lymphoproliferative disorders, particularly CLL. He is a principal investigator of several investigator-initiated and industry-sponsored clinical trials. He is also the principal investigator of the Mayo Clinic CLL database, which includes all the patients with a diagnosis of CLL seen in the Division of Hematology at Mayo Clinic in Rochester, Minnesota since 1995, who permits their records to be used for research purposes and which is linked to the Mayo Clinic CLL tissue bank. Finally, he is also a co-investigator on many studies that are funded by the National Institutes of Health and the National Institute on Aging. He has given presentations both nationally and internationally and has authored over 100 journal articles, book chapters, and other publications. He is a recipient of numerous awards, including the Shannon Timmins Leukemia Fellowship Award, ASCO Merit Award, Mayo Clinic Department of Medicine Career Development Award, Lymphoma Sport Career Development Award, Mayo Clinic Paul Calabresi Program in Translational Research Scholar Award, that is K12 CA090628, and the Mayo Clinic K2R Career Development Award. In addition to his clinical and research activities, he is very active in education and has served as a mentor to many residents and fellows, among other learners. He is an active member of the American College of Physicians, American College of Clinical Oncology, American Society of Hematology, and the Eastern Cooperative Oncology Group, that is ECOG-ACRIN. He also serves as a Mayo Clinic representative on the National Comprehensive Cancer Network, that is NCCN, for CLL, SLL, and hairy cell leukemia panel. He's going to lecture us today on monoclonal B-cell lymphocytosis, the risk of disease progression to CLL, and other clinical consequences. Well, thank you so much. Over to you, Professor Dr. Samir Parikh.
Hi, thank you very much for that very kind introduction and for the very nice invitation. You know, as a person who grew up in Bombay, in Mumbai, and went to medical school there, this invitation is very special for me. And so I really would like to appreciate the Mumbai Hematology Group for giving me the opportunity to speak today on this topic, which is near and dear to my heart, and also something that has a lot of new findings that have come about in the last several years that I hope to share with all of you today. Like was mentioned, monoclonal B-cell lymphocytosis is really where I'm going to spend the next maybe 30-35 minutes talking to you about, and then I'm happy to answer any questions at the end. So these are my conflicts of interest. I've received research funding as well as honoraria, but as per Mayo Clinic policy, I am not allowed to keep any of these research or honoraria dollars. They all go to Mayo Clinic. So the outline of today's talk really is going to be focused on the definition of monoclonal B-cell lymphocytosis, the risk of disease progression, as well as what are some of the other clinical consequences of this condition besides progression to CLL. And I think it's important at the outset for me to mention that this is a relatively new entity. I think we've all come to know what MUGUS is and what the risk of progression to multiple myeloma or amyloidosis is from MUGUS. And similarly, now we are learning about the possibility of this precursor condition called monoclonal B-cell lymphocytosis, which happens before CLL. And the question really is, what is the risk of disease progression? How do we define this condition? And what can we learn about what the consequences of this condition are in a person who may have been diagnosed with it? So to start off with, I'd like to define what MBL is. And as we all know, we can typically diagnose patients with CLL based on a peripheral blood CBC or a peripheral blood smear, which shows excessive lymphocytes. And as you can see on the peripheral blood smear here, we can see a number of smudge cells, which is pretty classic for a diagnosis of CLL in the proper clinical setting. And on the high power smear, you can see on the bottom left where you can appreciate the mature lymphocytes that are increased in number, as well as the smudge cells. And then when this is observed and there is a suspicion for CLL, patients undergo a peripheral blood flow cytometry. And as you can see over here, there is the typical flow cytometry markers that show the presence of a clonal B cell population. And you can see the presence of CD19 and CD10 negative, but CD19 positive B cells. These are kappa light chain restricted. There is expression of CD20, which is dim, but there is also the expression of CD5, which is an aberrant T cell marker that is expressed on B cells. And then with the positive expression of CD23, and now with the newer marker CD200, we can actually diagnose the presence of CLL-like B cells in the peripheral blood that would confirm this diagnosis. So the question is, how do you differentiate between CLL and MBL, which is really a continuum between the two disease processes? So as I mentioned, there is a monoclonal expansion of these B cells that express CD5, CD19, CD23, CD20 is dim, and CD200. And when the peripheral blood flow cytometry study is done, and if the absolute clonal B lymphocyte count is over 5,000, then that is considered to be a diagnosis of CLL. As you can see in this sort of peripheral blood flow cytometry report that we typically get here at Mayo, there will be a total WBC count listed and a percent lymphs at 59%, and the number of lymphocytes is 12.2. And then based on the flow cytometry study, they calculate the absolute clonal B cell count as 6.7. And so once this is greater than 5 or 5,000, or this is 6,700, that's consistent with the diagnosis of CLL. And here you can see that these B cells express the classic CLL immunophenotype. However, when the absolute clonal B cell count is less than 5,000, and there is no evidence of cytopenias or any lymphadenopathy or hepatosplenomegaly, then that is consistent with the diagnosis of monoclonal B cell lymphocytosis. On the other hand, if there is cytopenias that are present with marrow infiltration, then that is consistent with CLL despite a clonal B cell count of less than 5,000. And then finally, if there are no cytopenias, but there are either lymphadenopathy or hepatosplenomegaly by exam or CT scan, then that diagnosis is consistent with SLL. So these are three interrelated conditions, but it's a little bit confusing, but bottom line is if the clonal B cell count is greater than 5,000, then it's CLL. Otherwise, you look at the hemoglobin, the platelet count, and the exam findings to then classify patients into either MBL or SLL. So there have been a few changes in the definition of MBL over the years. So in the 1996 criteria for this diagnosis, it was really the absolute lymphocyte count that was thought to be the differentiating factor between a diagnosis of CLL and MBL. However, with the 2008 and now in the 2018 IWCLL guidelines, they've sort of shifted the goalpost to the right, where they now actually require the B cell count to be 5,000 and not really the absolute lymphocyte count. As you can imagine, the absolute lymphocyte count consists of T lymphocytes, NK cells, dendritic cells, et cetera, But so they have made it more specific, where they've now said that it needs to be 5,000 B cells. And so what that has really made the change is that then now a lot of patients that were previously classified as CLL have now become what we would define as MBL. And then based on the B cell count, we can further differentiate these patients into either high count MBL with a B cell count of between 0.5 and 4.9, or low count MBL where the B cell count is less than 0.5. And so as we will go forward in the talk, I will explain some of the differences between these two entities. But this is an important thing to remember, because this is the so-called screening MBL, and this is the so-called clinical MBL, where you would have differences in the clinical manifestations and outcomes of these patients. Again, it's important to mention that patients should not have any adenopathy or organomegaly or even cytopenias related to CLL infiltration at this stage, because if that's the case, then they would be classified as either SLL or CLL respectively. Now, truly, if you think about it, it's not just the total B cell count, but it's the clonal B cell count, because patients who have CLL or MBL, in addition to having a clonal B cell population, also have a polyclonal B cell population that is responsible for everything else that the patient has, meaning normal immunoglobulin levels, etc. And so truthfully, the bar should really be the clonal B cell count that should be at 5,000 or above to classify someone as CLL, and below 5,000 as someone with a diagnosis of MBL. And so this sort of really came about in this main paper that was published by Andy Rostron and colleagues from 2008, where they defined this condition, and they found that virtually everybody with CLL actually had a diagnosis of MBL that preceded the diagnosis of CLL when they found these patients were followed over time. And now with the latest WHO classification, 3 subtypes of MBL have been defined. And so what I mentioned in the prior slide with low count and high count MBL, that really pertains to the first 2 types of MBL, which is the CLL-like phenotype and the atypical CLL phenotype MBL, whereas a third entity called non-CLL phenotype MBL has also now been recognized, where patients may have a peripheral blood flow cytometry that shows a CD5 negative monoclonal B cell population, or CD20 that's moderate or bright. And so again, this would be inconsistent with CLL, and these would likely be patients who may eventually end up developing Waldenstrom's macroglobulinemia or marginal zone lymphoma or another B cell malignancy, which is not CLL. And so it's important to differentiate between these conditions as we identify a monoclonal B cell population in the peripheral smear. And so again, just to recap, MBL can be defined or divided into CLL-like and atypical CLL-like MBL. And both of these, the clonal B cell count will determine if it's low count or high count MBL, and then non-CLL phenotype MBL. It's important to point out that at this time, there are no high count or low count MBL categories that are established for non-CLL phenotype MBL. And in general, anytime this is found, everyone should undergo a full sort of screening for a concomitant lymphoma, meaning patients should undergo a bone marrow aspirate and biopsy and scans to look for the presence of any lymphadenopathy or splenomegaly, because they may have a lymphoma that may need to be treated. And this one final slide illustrates the point between low count MBL and high count MBL. And so low count MBL really is determined in population studies. So you take patients with a variety of in a sort of a blood bank, if you will, or in the population, and you do a large scale flow cytometry study, and you will find low count MBL in a proportion of patients. The median B cell count in these people is very, very small. It's 0.001 times 10 to the power 9 clonal B cells. On the other hand, in the clinic is really where we find high count MBL, where patients may be referred to us for lymphocytosis, and then you do a peripheral blood flow cytometry, and then you find these clonal B cells, but they don't cross the threshold of 5,000, and therefore they would be classified as high count monoclonal B cell lymphocytosis, and these 2 things have different implications, as we will hear in a few minutes. So, this is really how MBL is defined. The next question is, what to do when you find someone that has a diagnosis of MBL, and is this something that is different compared to what we normally do with early stage CLL? And so I'll just go over some of the prognostic biomarkers that have been established in CLL over the years, and then we'll talk about how these relate to patients who have MBL, because then that way we can make an adequate comparison between the 2. So here is a slide that actually shows that even the peripheral blood smear that shows smudge cells can actually be prognostic in describing outcomes of patients with CLL. So in this study, my colleague, Dr. Nowakowski, showed that if the smudge cells are greater than 30%, then these patients actually do better with an overall survival that exceeds several years compared to patients who have less than 30% smudge cells. It's really unclear why this is the case, but this is a very interesting finding. Over the years, we've relied on RISE stage to tell us how our patients are going to do. And this is the original RISE publication back in the 1970s. And then this shows sort of the corresponding survival from the Mayo Clinic series over a 20-year time frame, where you can see that the survival for particularly the higher risk RISE stage patients has continued to improve. And again, this very nicely illustrates the outcomes of patients with CLL. Now, certainly in patients with MBL, we really don't have any lymphadenopathy or ganomegaly or anemia and thrombocytopenia. And so by default, these patients are all considered RISE stage 0, but actually one stage even before that, because it's considered to be a precursor condition, just given where the clonal B cell count is. So what about flow cytometry-based markers? So we've all seen and heard about CD38. This is a very strong prognostic marker that actually shows the overall survival is inferior in patients who have a high expression of CD38. We have also seen time to first therapy and overall survival being segregated by ZAP70 expression. This is typically done by flow cytometry. And then there is a newer marker called CD49D that can also predict treatment-free survival and overall survival, where patients with a high expression of CD49D actually have a shorter treatment-free survival and a shorter overall survival compared to patients who have a normal CD49D expression, or actually the cutoff is 30%. And so all of these flow cytometry-based markers can also be helpful in MBL. Finally, we also know about the IGVH mutation status and its impact on outcomes in patients with CLL. Here you see the original publication from Hamblin and colleagues, where patients with unmutated IGVH genes had an inferior overall survival compared to those with mutated IGVH genes. And there are scores of papers that have confirmed these findings. And there are also a number of papers that actually describe the impact of treatment based on IGVH mutation status. Also, we know about the CLL FISH panel. Now, this is a very important study that actually helps us prognosticate patients. And these are the probes that are typically used in a FISH panel. This is the Mayo CLL FISH panel probe, which has a probe for deletion 6q, deletion 11q, deletion 13q, an additional copy of chromosome 12, and the presence of deletion 17p. And all of these can be very helpful in predicting how patients would do. And so here is the original paper from Donor and colleagues, the donor classification, which shows that patients who had deletion 17p had the shortest overall survival compared to all the other cytogenetic abnormalities. And on the right, you see time to first therapy is the shortest amongst patients who have deletion 17p compared to patients with 13q, where the time to first therapy is the longest. Now, over the years, we've all seen patients where, based on all the markers that have been obtained, the IGVH, CLL FISH, CD38, ZAP70, etc., there are some markers that point to a better outcome, and there are others that point to an adverse outcome. And so it's difficult to reconcile these into a single sort of prognostic score, if you will. And that's really where we took what is called as the CLL-IPI risk score and established that. But before I talk about that, I just wanted to highlight the study where we compared the baseline characteristics of patients with MBL to RISE stage 0 CLL, because those would be the most easily comparable groups of individuals. So at Mayo Clinic here, we took 415 patients with MBL and 554 patients with RISE stage 0 CLL. And you can see that the baseline characteristics of these patients was pretty similar in that their median age was comparable, the number of males were comparable, and then obviously patients had a lower absolute clonal B cell count. as would be expected, patients with MBL had a better prognostic status, if you will. So there was a higher number of patients with mutated IgB8 genes, with a lower median serum beta-2 microglobulin, and a similar proportion of patients with low-risk cytogenetics. Interestingly, the risk of TP53 disruption, which is defined as either del17p by FISH or TP53 mutation, was pretty comparable between the two groups of patients. And then the CLL-IPI risk score is where I was talking about, where we combined a number of these prognostic markers. That was pretty comparable between the two groups as well. And again, not surprisingly, there were more patients in the low-risk group in MBL compared to CLL. And so this is where the CLL-IPI is what was devised based on a combination of about 28 different risk parameters. And the CLL-IPI is a combined score that you add up with all of these points and then get either a low, intermediate, high, or very high risk of disease progression based on these 5 parameters. So age greater than 65, clinical stage that is greater than RI stage 0, unmutated IgB8 genes, beta-2 greater than 3.5, or the presence of TP53 disruption. And based on what the patient's ultimate score is, you can then see that this actually predicts how fast a disease is likely to progress. So historically, the disease risk progression from MBL to CLL requiring therapy is approximately 1 to 2% per year. Now, that is very different according to this particular CLL-IPI risk score, because you can see that patients in the low risk score have a lower risk of disease progression compared to those in the high risk in green over here. And in the very high, it's down here at the bottom. That's probably because there's just a very small number of patients here. And so here in this table, we combine the high and the very high risk group of patients together, and you can see it's about 41 out of close to 440 patients. So that's about 10% of all patients with MBL. But you can see that the 5-year estimated risk of treatment here is 40% compared to 7% in the low risk group of patients. So here in the low risk is really where the 1 to 2% risk of disease progression is what is quoted generally. But if you have intermediate or high or very high risk, the risk becomes much higher. Now compare this to the time to first therapy in RI stage 0 CLL, and you will notice that it's roughly twice as much in the low risk group. It's from 7 to 15%, from 15 to 34%. But what I want to draw your attention to is the fact that patients with intermediate and high or very high risk CLIPI group in the MBL stage have a higher risk of disease progression compared to patients with low risk CLL-IPI with RI stage 0 CLL. And what this suggests is that it's really the biology of the disease, meaning the IgB8 mutation status, the FISH, etc., that drive the risk of disease progression, and not an arbitrary number of the definition of MBL versus CLL with this clonal B cell count of 5. And so again, I think to the extent that these can be obtained, it would be very helpful to counsel patients as to when their disease is likely to progress over time. Now, we've all heard about the somatic genetic alterations that happen in CLL, and similarly, we can use a next generation sequencing panel to determine which patients are likely to have which mutations and if they can predict the time to first therapy. And so here is a 90 gene NGS panel that we can use in patients with MBL and CLL, and that can identify mutations in a number of these genes. And so when we ran this analysis in our patients here at Mayo to look for what is called as a tumor mutational load, and this was defined as 0 mutations, 1 mutation, or 2 or higher number of mutations, this was nicely able to segregate time to first therapy according to the number of mutations, suggesting that the higher the mutation score at baseline, the higher the risk of a patient requiring therapy over time. So how do these patients do? Meaning, what is their survival compared to the general population? So I talked so far about how can we risk stratify these patients. we can use the CLL IPI risk score to predict who's going to have faster progression of disease. And that is about 1 to 2% on an average per year. But the CLIPI can actually even enhance our ability to predict who's going to have faster progression of disease. And this is faster progression of disease to CLL requiring therapy, because that's the more clinically relevant outcome as opposed to just progression to CLL. With respect to overall survival, here in red is the expected survival of age and sex matched general population in the state of Minnesota to the patients that we published in that paper in Blood. And you can see that the survival of individuals with MBL was longer, which was very surprising to us. And we still don't have a very good explanation for this. But this was really driven by those with low risk CLL IPI risk score, whereas those with intermediate risk and high and very high, which I'm not showing here, their survival was similar to the age and sex matched general population. Now, some of this may be referral bias because maybe the healthy people make it to Mayo to be seen relative to other patients in the general population, and maybe people who are seen here are a little more health savvy and health conscious, and that's perhaps why the survival is better, but this remains to be clarified. So I've talked about the risk of progression to CLL requiring therapy, but what about other clinical consequences of MBL? And so here is a paper that we published several years ago now that actually shows that patients with MBL, much like patients with CLL, have a higher risk of infectious complications. And so in this Kaplan-Meier curve over here, you can see that these are control patients who don't have CLL or MBL, and their risk of hospitalization for a serious infection compared to patients with MBL in the dark gray line and then CLL in the light gray line. You will see that the risk of serious infections requiring hospitalization is much greater compared to the control population, suggesting that there is maybe some sort of an immune dysfunction that is present even at the time of diagnosis, which is not related to treatment, because obviously we don't treat anybody with MBL at the first, when we first diagnose it. And here you can see the types of infections that happen in this group of patients, where you can see that it's really gram-positive bacteremia, again, gram-negative bacteremia, and a variety of other infections that can happen in these patients, suggesting that this immune dysfunction really contributes to adverse outcomes, and not just progression of MBL to CLL requiring treatment, but it's really a risk of infection that can happen. And this is adjusted for age and sex, which means that a patient may have this increased risk that is inherent to the presence of high count MBL and not really related to age-related immune decline. Similarly, we've also seen an increased risk of non-hematologic malignancies in MBL compared to healthy controls. So you can see over here that patients who have MBL, much like CLL, have a higher risk of non-hematologic malignancies like colon cancer, prostate cancer, etc., compared to healthy controls, suggesting that this immune dysfunction also allows the secondary malignancies to occur. And that's, again, important for patients and healthcare providers to know, because these patients, much like patients with CLL, should be screened for secondary malignancies on a regular basis. So I talked about the immune dysfunction that we can see in these patients. And so here are some examples of what these could be. So here is a paper from the Canadian CLL group, which looks at immunoglobulin levels in patients with MBL. And you can see that the IgG level is similarly low in MBL compared to RI stage 0 CLL. And similarly, IgA and IgM levels are similarly low in both MBL and RI stage 0 CLL patients, suggesting that this immune dysfunction with hypogammaglobulinemia starts early on when the disease is identified. Interestingly, the presence of a low IgA can also predict for a faster time to first therapy in both the MBL as well as the RI stage 0 CLL cohorts. And then we've done some work looking at T cell dysfunction in MBL. And so here you can see that compared to controls, the proportion of patients with a higher expression of CD8 positive, CD160 positive T cells, which is a marker of T cell exhaustion, is increased in individuals with MBL. And there is also a higher number of natural killer cells that are present in MBL patients at the time of diagnosis. In fact, when patients have progression of disease with MBL, there is an increase in the number of CD8 positive, PD1 positive T cells, which are exhausted T cells over time compared to patients who do not have any progression of their MBL. And we've also done some T cell immunological synapse work, which shows that the T cell immunological synapse that occurs in individuals with MBL is worse compared to those with healthy controls. And this suggests that perhaps these are some of the reasons why patients with MBL have immune dysfunction that contributes to the increased risk of infections, as well as increased risk of secondary malignancies. And of course, this remains to be expanded. The work needs to be increased for our better understanding whether this is truly the case and how can we reverse this immune dysfunction. So I've talked about high count MBL, the risk of disease progression, overall survival of these patients, and some of the other clinical consequences, including the risk of increased infections, secondary malignancies in high count MBL, which is really the clinical lymphocytosis that we see in the clinic. But what about screening or low count MBL? And so these are patients who are not seen in the clinic. These are patients who in the population sort of studies where we screen populations of patients for the presence of MBL, we can find it, and they don't even know that they have MBL because it is found at a very, very sensitive flow cytometry study. So what about these patients? Do they really have a clinical condition, and what do we do about this? So here at Mayo, we conducted a large study of over 10,000 individuals where we looked for MBL in people who otherwise did not have a hematologic malignancy. And interestingly, we were able to find these MBL clones in roughly 17% individuals. And the vast majority of them had low count MBL, which is the clonal B cell count of less than 0.5. And you can see that as an individual's age increases, the low count MBL percentage also increases in such that folks who are over the age of 90, roughly 40% of these individuals have low count MBL. Now that's obviously a very high number. And as you can see, the number increases with every decade of life increase. So a question really becomes, if someone does not have MBL, are we all destined to develop MBL, right? So if we lived for 100, 110 plus years, will we all get MBL? Maybe, maybe not. It's hard to know that. But I think it's interesting to see that in individuals who did not have MBL at the first screening study, about 13% actually developed low count MBL subsequently. Another question that comes up routinely is, what about the patients who do have MBL and that was identified over at the first time point? Is this just a small aberrancy in the B cell numbers or B cell count that just reverses itself? And that does not appear to be the case, because among these 58 individuals who had MBL initially and who submitted a subsequent sample, this clone was present in 94% of individuals, suggesting that it's not a one-time thing. It continues to be at this higher number even after a long period of time. And in roughly a third of these patients, there was a significant increase in the clonal B cell number, suggesting that these patients remain at risk for developing worsening white cell count or total B cell count. And here is just an illustration of how these patients do. So on the left here is where the clonal B cell count doesn't change very much over time. These are paired samples, and this is the percent of clonal B cell count in the y-axis. It stops at 10%, and you can see that these are very, very small changes. In contrast, in the right graph here, you will see that there are individual patients that have an increase in the clonal B cell percentage between two time points. And this is really where we suspect that there is some degree of progression happening, but we are trying to understand what's the difference between this group of patients here and this group of patients here, because that may allow us to predict again which of these patients with a very, very small amount of clonal B cells can experience progression of disease over time. And this is done using at least an example over here, multi-parametric flow sorting, and then we do next generation sequencing studies to identify which mutations are present in these clones that can predict for a faster risk of disease progression. And similar data have also been published from our colleagues in the Spanish CLL group, where again, they show that individuals with low count MBL have persistent lymphocytosis that is present even up to 7 years after follow-up. And in fact, they also show that these individuals have a lower overall survival compared to controls, suggesting that this condition may be a harbinger for more adverse outcomes compared to simply progression to CLL requiring therapy, because there is a very, very small risk of these patients having progression of disease to CLL. So what are some of the other clinical consequences? So again, much like high count MBL, in low count MBL, we see a 1.5-fold increased risk of serious infections requiring hospitalization. And again, this is amongst the cohort that was screened for low count MBL. You will also see a 7-fold higher risk of lymphoid malignancies in low count MBL compared to controls. And then finally, there is also an increased risk of cutaneous melanoma in these patients compared to controls, all of which suggests that there is perhaps some sort of an underlying immune dysfunction that leads to all of these clinical consequences, even at the stage of low count MBL at the very, very low clonal B cell count. Finally, what about non-CLL phenotype MBL? We talked about MBL, which is the CLL phenotype, high count and low count CLL phenotype MBL. Here are some preliminary data on non-CLL phenotype MBL. So again, from the same biobank cohort, and these analyses need to be updated, but we looked at the first 2,594 adults who were screened from that same biobank study. And of the 336 individuals who were found to have MBL, roughly 18% had non-CLL phenotype MBL. And again, here you can see that similar to the CLL phenotype MBL, the age plays a very important role, where the higher the age, the higher the proportion a patient may have non-CLL phenotype MBL. And again, these individuals are more likely to go on to develop a hematologic malignancy, roughly 5% compared to 0.2% in people who don't have a non-CLL phenotype MBL. And their estimated overall survival at 7 years was significantly shorter compared to those who did not have MBL, although after adjusting for age, sex, and a self-reported prior non-hematologic history of cancer, this effect was attenuated. Again, this is early data. We need to update these data and external validation needs to happen. But this does appear that non-CLL phenotype MBL is an important marker of future hematologic malignancy that can be important for us to screen for. And so here is a very nice summary from our colleagues in Australia about approach to MBL in clinical practice, which I think is very nicely done. And so here, if you have someone that has a CLL B cell clone, the first thing to do would be a peripheral blood flow cytometry. And if you see a CLL phenotype MBL, and this is where the low count MBL comes in, if it's less than 0.5, then you check immunoglobulins, confirm COVID and other vaccination status, because there are data to suggest that individuals with MBL have an inferior response to vaccination compared to healthy adults. And then these patients typically do not require any routine follow-up, but it's important to counsel and make them aware of the risk of infection and secondary malignancies. But they don't need to be seen in the hematology clinic on an ongoing basis. On the other hand, if you have a patient with high count MBL of the CLL immunophenotype, we typically would recommend, much like patients with early stage CLL, annual clinical review, physical examination, with yearly looking at what their blood counts are doing, and then risk of infection and vaccinations and secondary malignancy. For patients with atypical CLL phenotype, it's similar to the CLL phenotype MBL, except it would be very important to ensure that these patients do not have mantle cell lymphoma. And so to get a CLL FISH profile to rule out 11-14 translocation, or other studies, if they are CD5 negative, typically to look for Waldenstrom's or marginal zone lymphoma would be important. And then depending on the type of diagnosis that these patients have, if they do have lymphoma that needs to be treated, they obviously need to get that treatment. If on the other hand, they do not have any evidence of a lymphoma like lymphadenopathy or bone marrow infiltration, then these patients need to be followed up every 6 to 12 months. And if there is evidence of disease progression, then appropriate lymphoma management needs to happen. So I'd like to summarize what we talked about so far. So MBL is a precursor condition to CLL. We talked about how you can divide it into CLL phenotype and non-CLL phenotype MBL. And within the CLL phenotype, there is high count and low count. For individuals in the high count MBL bucket, the rate of progression is about 1 to 2% per year. Again, this is CLL requiring therapy, not just CLL, because CLL requiring therapy is the more important clinical endpoint. And then this risk can be better predicted by using the CLIPI. And I mentioned that these individuals have a high risk of infections and secondary malignancy, and these patients should be seen annually in hematology. Their overall survival appears similar, maybe better compared to the general population. On the other hand, low count MBL to CLL requiring therapy, the risk is exceedingly low, and therefore no typical follow-up is required in hematology. But these patients do have an increased risk of serous infections, and further work needs to take place to understand what the immune mechanisms might be that are responsible for these findings. And so I think, like I mentioned, non-CLL phenotype MBL, we still need to do much more work. There is a lot of interest in defining the immune deficiency that is present in these patients. And then I think of great interest to me is to try and find out what happens to individuals with MBL of other ethnicities, African American, Hispanic, Asian population. There's obviously a low incidence of CLL in India. What are some of the risk factors? Is the incidence of MBL high in India, and there is just not enough screening that's happening? And so these are all questions that hopefully we will be able to answer over the next coming years. And with that, I'd like to end, and I'd like to acknowledge the Mayo Clinic CLL Early Detection and Interception Research Team. We have a large group of individuals working on this here at Mayo, and we collaborate with many people across the country and across the world, actually. And with that, I'd like to thank you for your attention, and I'm happy to answer any questions.
Thank you so much, Dr. Samit Parikh, for a beautiful topic on monoclonal B-cell lymphocytosis and for enlightening us on this topic of monoclonal B-cell lymphocytosis. Many things which we were not knowing was eye-opener for us, and many things which we learned from you today. Thank you so much for this topic. A wonderful lecture. And we have some Indian colleagues over here who will have a question answer session with you. And I request all our discussants to please put the raise hand signs first so that we can start with our question answer session. So to start with, we have Dr. Sandeep Bartake. Dr. Sandeep Bartake, your question, please.
Yeah. Thank you, Dr. Samir. It was an excellent talk. My question is there increased risk of autoimmune phenomenon in these patients? And secondly, another interesting finding that you mentioned in your cohort, the survival was better than the general population, but they still, despite having increased risk of infection and non-hematological malignancies. So how do you explain that?
Yeah, so thank you for your question. So I think there is no increased risk of autoimmune conditions in individuals with MBL, because you are absolutely right. We would expect that if someone has an autoimmune condition, they would have maybe polyclonal increase in B cells, polyclonal hypergammaglobulinemia. But when we compared the risk of autoimmune conditions between those who did have MBL and those who did not, there was no significant difference. In fact, we'd also looked for other comorbidities like diabetes, hypertension, etc., and there was no difference between the two cohorts. So our perception is that it's really the MBL clone that may be driving these clinical manifestations. because obviously the other alternative is that maybe this is just a marker of another entity that's really driving the adverse clinical outcomes, but it's hard to know for sure. The best that we could do was to compare some of the known comorbidities, and there was no difference between the two groups, one with MBL and one without. Now, of course, this is not a randomized study. This is sort of a cross-sectional study where we screen people for MBL and found, roughly 20% with MBL and the others who did not. So it's not perfect. And I don't think we can ever do a randomized study to learn this phenomenon. But that's really the difference that we have found, which is basically only the presence of MBL and no MBL. Everything else was pretty similar between the two cohorts. To answer your second question, I don't know. I think your question is exactly what we've been wrestling with, is how do we reconcile the finding that these patients have an increased risk of serious infections and non-hematologic malignancy, yet we are talking about survival being better. I want to say, I'm biased. Of course, I work at Mayo. If you come to Mayo Clinic, you will live longer, but that's, not really a valid answer. I really think that that's a referral bias. I think the people who come to Mayo, who seek out care, who come here on a regular basis, we make sure that they get their vaccinations, we make sure that they get their secondary cancer screening tests done, etc. Maybe those things are the ones that actually allow patients to have a longer lifespan compared to the general population, but that's a hypothesis. I really think it's a referral bias more than anything else.
Thank you. Thank you.
Thank you so much, Dr. Sandeep. Dr. Saswata Saha, your question, please.
Good evening, sir. Excellent presentation, sir. Sir, my question is that you said that there are increased risk of infection in low count as well as high count monoclonal B cell lymphocytosis. So, and there are also incidences of hypogammaglobulinemia. So, is there any benefit of IVIG or anything for prevention of infection in these patients?
Yeah, thank you for that question. Generally speaking, we have not given IVIG replacement in these patients because generally speaking, we would reserve the use of IVIG in patients where the IgG level is less than 400 and they have recurrent serious infections. Here, what we see is, although the immunoglobulin level or the IgG level is low, it typically is not lower than 400. And so we are trying to understand what is it besides the low immunoglobulin level that actually predicts the risk of infection. And so we think there are T cell dysfunction and NK cell dysfunction and other immune parameters that probably are responsible for the increased risk of infections, which obviously, as you know, are not easy to fix. And so, we can give IVIG, but typically the immunoglobulin G levels are not as low as we would see in someone with CLL who's received, bendamustine rituximab or FCR or other such treatments.
Thank you, sir.
Thank you, Dr. Saswata Saha. Dr. Kaushik, your question, please.
Good evening, sir. So in your experience, what is the percentage of non-hematological malignancies you have observed in your practice with particularly the high count MBL? And is there any specific screening or follow-up recommendation in this subset if you do follow-up mind?
Yeah, thank you for that question. So I think, it's hard to give a number as to what the exact percentage is of secondary malignancies, but in that paper that we published, the risk of secondary malignancies was about 10 to 20% after a median follow-up of about 8 years. Now, we've sort of wrestled with this ourselves in that, the general recommendations, at least in the US, for mammograms, is starting at the age of 40, colonoscopy starting at the age of 45. Prostate cancer screening, depending on what the patient's risk factors are, etc. So we typically do not recommend doing anything differently, meaning anything over and above what is generally recommended. So we follow the guidelines of when a patient should get screening, regardless of whether they have MBL or not. I think the point that we really emphasize to our patients is that screening is one of those things that gets by the wayside. People forget about it. Life gets in the way. People are busy. They don't want to go get a mammogram. They don't want to go get a pap smear, etc. But here we really emphasize that, look, because of the diagnosis of MBL, you're at a higher risk of developing these complications. And so it's very important that you not forget getting your mammogram and your colonoscopy and the other cancer screening tests done. There is no increased frequency. So if a colonoscopy needs to happen once every 10 years, it's once every 10 years. You don't have to do it once every 5 years simply because there is a diagnosis of MBL. At least there is no data to suggest that we should do it more frequently. The one piece that, at least in the US, that's very important is that patients should also go see a dermatologist for a full body skin exam because of the high risk of skin cancers. And I think that in particular is important because, again, that's one of the things that's not recommended very often and people don't do it. But we have seen increased melanoma, Merkel cell cancers, and squamous cell and basal cell cancers of the skin. And so I think it's important that everyone with a diagnosis of MBL be referred to a dermatologist.
Thank you for that.
Thank you, Dr. Kaushik. Dr. Sandeep, Bartek, you have another question?
Yeah, so have you looked at immunoglobulin subclasses and B cell, again, subclasses like memory B cells or switched B cells? And secondly, another question was, first, please answer this. I forgot my second question.
Okay, thank you for that question. So I think there are two papers that have looked at immunoglobulin subclasses, IgG 1, 2, 3, and 4. And the results are sort of mixed. And this is not in the context of MBL, this was in the context of CLL. And one paper from the Australian group suggested that they don't matter as much. It was really the total immunoglobulin levels that mattered. And then there was a group from Sweden that published that, no, it's really the immunoglobulin subclasses do matter, and it would be important to check for those. I don't think we have really looked at immunoglobulin subclasses in MBL, and I would not recommend checking those because in the vast majority of patients, although there is hypogammaglobulinemia in about 20% of these patients, the IgG levels are not below 400. And so I don't really think that replenishing IVIG in these people is going to prevent serious infections from happening. I think there are other things at play that really drive the risk of infections. Also, to your question, there is ongoing research, and we are doing some of it where we are trying to understand, which type of B cells are a problem. Is it the class switched memory B cells or specific subsets of B cells that may be abnormal? So I don't really have an answer for that right now, but hopefully in the years to come.
Yeah, thank you. I remembered another question. So like in CLL, is there increased risk of familial, the predisposition for MBL?
Yeah, that's a great question. Thank you for asking. Yes, absolutely. So, we have a very strong familial CLL program here at Mayo where we screen families of first-degree relatives with CLL. We've seen an increased risk of MBL in individuals with MBL as well. And so I think that, has been shown consistently. In fact, based on that work, we've now, a very common question we get asked in the clinic is, I have CLL or I have MBL, what are the chances that my son is going to have, these diagnoses? And we typically will say, there's about an 8-fold increased risk of CLL in first-degree relatives with CLL. We have now done GWAS studies and other things where, there's a risk score of what is called as a PRS or a polygenic risk score, which combines the weighted score of about 43 single nucleotide polymorphisms or SNPs that can assess this score and that can predict what the likelihood is of someone developing CLL or MBL. Now, it's not perfect because this inherited sort of risk explains only about 15 to 20% of what an individual's risk of developing this condition is, because a lot of it is still yet unknown, environmental impact, etc. So I think a lot yet needs to be done to be able to properly and confidently counsel someone that, yeah, your father had CLL or MBL, and these are your chances of developing it.
Thank you. Thank you so much.
Thank you, Dr. Sandeep Bartake. Dr. Saswata Saha, your question, please.
Sir, given the almost equal survival of high count MBL with normal population, so how frequently should we do routine follow-up checkups for this patient, and how extensive or should be the follow-ups? What investigations or only clinical we should do?
Yeah, so I think overall survival of patients with high count MBL is similar, but I think that's really driven by the low count MBL patients, by the low CLL IPI risk score MBL patients. What we routinely will do is we will get a CLL IPI risk score on everyone. So, that may be difficult to get in everybody, particularly in India. Because I understand that IGBH mutation status and FISH, etc., obviously are expensive and maybe difficult to obtain from reliable labs. But here, we are able to get IGBH mutation study and CLL FISH on everyone, and so then we assign the CLL IPI risk score, and then particularly in patients who have intermediate or high or very high risk scores, we'd like to see them at least on a yearly basis, because the risk of progression of disease to CLL requiring treatment is pretty high. So it's about 40% at 5 years. And so I think that's much higher compared to the average sort of, 10 to 15% at 5 years. And so I think the low risk patients can be, sent back to their primary care physician, and they can get a yearly CBC and be referred back to hematology if they have disease progression. Would you be wrong in asking a high risk or a very high risk, high count MBL patient to be seen by their primary care physician? I don't think that's wrong at all. They can get yearly counts done. They can see their primary care physician and come back to hematology if there is disease progression that would require treatment.
Thank you, sir.
Thank you, Dr. Saswata Saha. Dr. Jaswin Tini, your question, please.
Yeah, sir, thank you for such a wonderful talk. My doubt is, do we have to do IGHP mutational status for low count MBL as well in the front line, along with CLL FISH panel? And second, do we have to repeat it again when the patient progresses to CLL, sir?
Yeah, thank you for that question. So I just want to say, low count MBL, typically, you wouldn't find this patient in the clinic, right? I mean, these people actually have low count MBL. You wouldn't even know that because it would only be in the context of a screening study. So, for example, there was a study done here where they wanted to see how many people have low count MBL who came to a general medicine clinic. So they went to the OPD and found a whole bunch of people and they screened them. They didn't know that they had MBL. Their blood counts were otherwise completely normal. Another study done here was where, people were donating blood. So in the blood bank, they found a residual, small amount of blood after the blood was donated. And they ran that for looking for how many people had MBL. So all of these people were donating blood and they had normal blood counts, right? And so the amount of CLL-like clonal B cells present in low count MBL is exceedingly small. And so these people typically won't be in the clinic. However, it's of research interest because we're trying to find out who gets to do CLL. Do they start at low count MBL, then do they become high count MBL, and then do they become CLL where it's now evident on physical exam, etc., and then they need treatment. So we're trying to investigate this from the very early onset of the disease process. Having said that, individuals who have a low count MBL where the amount of clonal B cells is very small, it's not possible to do IGBH studies because the amount of cancer cells is so small to be able to get a correct answer. In fact, even in the high count MBL stage where the clonal B cell count is 2.5, 2.9, the median, you can barely get the IGBH studies done at that time because you really need about 1,500 to 2,000 clonal B cells to do IGBH mutation studies. So for low count MBL, it's not possible to do it. Having said that, let's say you do have a patient high count MBL or with CLL where you do IGBH mutation studies, Generally speaking, the IGVH mutation study does not change over time. So patients may receive FCR, BR, chlorambucil, whatever treatment they want, that they have had. The IGVH mutation status does not change. So we typically will not repeat it. We will, however, repeat CLL fish because obviously there is a lot of data suggesting that clonal evolution happens once patients receive treatment. So patients develop 17p deletion or 11q or other things that may change, but the IGVH mutation status does not.
Thank you, sir.
Thank you, Dr. Jaswantini. We have some couple of questions from the audience. Some are repeated. So I will just read out to you. First question is from Dr. Ghatikar Anshu. She asks, she wants to know that does MBL differ for different sex, male or female genders?
Yeah, so much like CLL, where there is a preponderance, about 65 to 70% individuals or patients with CLL are males compared to females. There's a very similar risk ratio in MBL as well. And I don't think the type of MBL really changes according to the patient's sex.
Thank you. Another question from Dr. Krishna Ratham Kannan. Do you routinely advise bone marrow biopsy in high count MBL?
No, I don't think it's necessary. And so even in early stage CLL, when a patient is diagnosed with CLL, we typically would not do a bone marrow biopsy. So unlike many other sort of precursor conditions like MUGUS or IgM MUGUS, where you have to differentiate between MUGUS and smoldering myeloma or smoldering Waldenstrom macroglobulinemia from active disease, where there is a cutoff of 10% or 60% or something along those lines. We don't think that similar data are required for a high count MBL or even early stage CLL patients. So in a research study that we had done here, where we offered to actually pay patients to get a bone marrow done with MBL, we found that the average percent involvement in the bone marrow with high count MBL was about 20%. And then, that really didn't matter if someone had 30% or 40%, they didn't have a faster risk of disease progression. And so, a bone marrow really does not help in high count MBL or even in early stage CLL where patients don't need treatment.
Absolutely. Thank you so much. Another question from Dr. Kannan. Again, the same question. How frequently do you repeat blood counts for high-risk MBL?
So we typically will see patients once in 6 months to make sure that things haven't changed completely, because sometimes patients can have fast disease progression that doesn't really obey the CLIPI score. But otherwise, we see these patients once a year in the clinic, much like early stage CLL patients. And then some of the patients with the low risk CLIPI, high count MBL, we will ask them to continue following up with their primary care physician.
Thank you. Another question from Dr. Nikhil. Again, the same thing. Is there any role of monthly IVIG prophylaxis in MBL patients with recurrent infections and low immunoglobulin levels?
Yeah, so I think we do have a few of these patients where the IgG level is very low, less than 400. So I would say recurrent serious infections requiring hospitalization where the IgG level is less than 400. You should certainly think about IVIG replacement therapy, but I don't think that these patients, at least in my opinion, have the low IgG level because of MBL. In those patients, I would think about other immune deficiencies such as combined immunodeficiency, etc., which may require IVIG therapy even outside of this diagnosis of MBL. So I will typically have these patients go meet with an immunologist to do other studies to try and figure out what else is going on, because I wouldn't expect a patient with MBL who's never needed treatment to have very low IgG levels.
Thank you. Another question from Dr. Kannan. Is there any association with COVID-19 infection and the incidence of MBL?
Yeah, so of course, a COVID question had to come, right? Because that's a sign of our time. So we actually looked at this in the Olmsted County, so where Mayo Clinic is based, because we wanted to be confident of what we find, because we wanted to make sure that we are able to accurately diagnose COVID and look at how this would fare. So interestingly, what we saw was that the risk of COVID infection, and so this is before vaccination, because we did not want to take vaccination into account. So before vaccination became routine here, the risk of COVID infection was actually similar. So acquiring COVID infection was similar between those with MBL and those without MBL. However, once someone with MBL got COVID infection, the risk of hospitalization because of COVID was about 3 times higher compared to somebody who did not have MBL. Now, remember this, patients themselves, with low count MBL, they don't know that they have MBL, right? And the treating physicians also don't know that these people have MBL, because this is all done in the research setting, right? And so it's intriguing to us that, the risk of acquiring COVID is not different, but the risk of someone's COVID infection getting serious enough that they would get hospitalized is about 3 times as high. So it is consistent, the risk of serious infections, bacterial infections, etc., and the risk of COVID, serious infections as well is similarly high. So again, we do think that there is some sort of an underlying immune deficiency that's driving this. We just haven't been able to pinpoint it or know how to fix it, because the obvious question is, how can you treat this? The only treatment really would be to reverse the B cell clone by CLL directed treatment, which of course we are not ready for, because we just heard, this week and last week from the CLL-12 study, which is the German-led study where patients with high-risk CLL, not MBL, were treated with ibrutinib compared to placebo, and there was no difference in outcomes, right? So if in CLL there is no difference in outcomes, MBL is a bigger bar to cross. So we are obviously not ready for that discussion yet.
Thank you. I have another question. In one of our webinars just previously undertaken in the last week, one of the audience had asked that one patient has developed Hodgkin's lymphoma and has come with a newly diagnosed Hodgkin's lymphoma, and one patient has come with the newly diagnosed DLBCL. Patient was treated for Hodgkin's lymphoma, patient was treated for DLBCL, and after the chemotherapy, the patient has developed another node, and that node is showing as CLL, chronic lymphocytic leukemia. So whether you missed CLL before, that would be the incident happened, because after developing a CLL after Hodgkin's lymphoma or DLBCL was a question mark actually. So can this happen that you missed CLL and the CLL has converted into DLBCL or Hodgkin's lymphoma, and that CLL was missed at the initial event, which was taken place 6 months back. And now the patient has been treated for DLBCL or Hodgkin's lymphoma, the disease has gone and the CLL has superseded again.
Yeah, no, so that's a good question. So that is certainly possible, and we have seen that. Generally speaking, we've all seen patients who have a diagnosis of CLL, and for many years, they have it, they may have needed treatment, and then they, develop symptoms of, an aggressive lymphoma. You biopsy, find large cell lymphoma or Hodgkin lymphoma, and then treat them accordingly. There are some patients where they just don't come to clinical attention because they're CLL. I mean, they never went to a doctor. They don't get blood counts done. They may have had a lymph node for a few years that they may have ignored, which was all CLL. And suddenly now they have B-type symptoms, and they have now had transformation to, an aggressive lymphoma. And you biopsy that particular node, and you actually only see the high-grade lymphoma. There may be CLL elsewhere that may be present for several years that was not diagnosed. And now you just ended up finding the PET avid lymph node that was biopsied that showed the aggressive lymphoma, and you treated that patient. And so that happens a lot. Thankfully, these patients, do well, because if their CLL has not required prior therapy, and if they first are diagnosed with a concurrent, if you will, CLL and aggressive lymphoma, these patients tend to do better, because generally speaking, the lymphoma is unrelated to the CLL. The clonal relationship is different. And so the outcomes are better. But, it is one of those things where, how do you manage such a patient? Because if you've given R-CHOP or you've given ABVD, you would expect some amount of response to the underlying CLL as well, right? Because these drugs work for CLL also. but not necessarily as well. And so it wouldn't be surprising to find a lymph node at the end, in some patients that may then turn out to be CLL. But it's very likely that they had CLL for several years before that just went undiagnosed.
Thank you. Dr. Sandeep Bartake, you have a question?
Yeah. Similarly, I wanted to ask, have you come across, a situation where, lymph node biopsy is done for something else, or, for as a routine during surgery, and you come across a B cell monoclonal population in the small lymph node, and there's nothing in the blood or bone marrow, and what do you call it?
Yeah, that's a great question. So that happens all the time, right? Because, patients go for prostate cancer surgery, they sample the prostate, the periprostatic lymph nodes for prostate cancer staging. And, lo and behold, they'll find a small monoclonal B cell population in the lymph nodes there, same for colon cancer surgeries, etc. So there is an entity called as the tissue equivalent of MBL, which is basically the presence of these small monoclonal B cells in these lymph nodes or other tissues, but with no circulating clonal B cells, or a bone marrow that has very small amount of these B cells. So typically, we will call the pathologist, we will speak with them. There generally is the presence of these small cells, but there is no sort of prominent proliferation centers. There is no surrounding sort of reaction to these clonal B cells in these small lymph nodes. And we will typically just ignore that. We will obviously, stage the patient completely. So we'll get a CT chest, abdomen, and pelvis, and sort of say, yeah, this is early stage tissue equivalent of MBL. Nothing needs to be done. But because I don't know enough about this condition to be sure of how to counsel my patient, I will likely have that patient come back to me for a few years, with yearly follow-up. So I can really do a good exam and make sure that they're not developing SLL, because the chances that this person will develop lymph node-based disease is much higher compared to blood-based disease. And so the primary care physician can do a CBC to look for progression, but I would really rely on my own exam to make sure that there is no progressive lymphadenopathy over time.
Thank you. Is there any size cutoff, like, 2 centimeter or anything like that?
Yeah, so that's a controversial area. Some people say 1 or 1.5 centimeter in size, but I think that is an enlarged lymph node. 1.5 centimeter is what is considered to be abnormal. But again, I think it's important to remember that if you do have that big of a lymph node, then I would really think about that as an SLL and not MBL, if it's 1.5 or 2 centimeters in size. And that typically, once you have that big of a lymph node that shows some amount of B cells that are clonal, then there will likely be other sort of lymph nodes that may be enlarged as well. And you may then be invoking a diagnosis of SLL as a equivalent of MBL.
Thank you.
Thank you, Dr. Sandeep. Dr. E. Montant, you have a question? Yeah, you're muted. Can you please unmute yourself?
So thank you for the excellent talk. My question is regarding SLL as a second tumor transformation. Similar to previous question, we have a patient. He is initially CD30 and CD30 strongly positive, EMA positive, and EBV positive, and CD4 weak expression or CD15, CD4 and DIA1, and CD20 and 79 it is negative. Also, PAS5 and CARTA3 are negative. So initial tumor is likely to be negative ELCL, and rebiopsy of the residual lymph node show that SLL, CD5 positive, 23 positive, and 10 negative. So my question is, sir, do you have any experience of similar cases and like D2B transformation and management suggestion for that? Yes,
Yeah.
residual lymph node is about 3 centimeter. Yes.
Got it. If I can just clarify, so did you say this was ALK negative anaplastic large cell lymphoma was the official sort of path diagnosis?
Yes, likely to be EMA positive, EBV is positive, and CD30 positive, DI1 positive, and CD4 positive but negative for CD2 and CD3 and other B cells marker.
Yeah, so I think this is a rare sort of complication. So we've seen Hodgkin lymphoma, we've seen plasmablastic lymphoma, we've seen I don't remember if I've seen anaplastic large cell lymphoma, happening in patients with CLL. At least I can't remember a patient. But I'm surprised. I think it's important to recognize that here what we try to do for all of these secondary lymphomas that happen in patients with CLL is to try and determine if these are clonally related or not. Meaning, if the CLL clone, the same clone that went on to become large cell lymphoma. That's the most classic that we do. With other types of lymphomas, particularly Hodgkin lymphoma, plasmablastic, or anaplastic large cell lymphoma, it's very hard to establish that relationship, whether it was the CLL cell that became any of these large or aggressive lymphomas. In general, my approach is that I consider these as de novo patients outside of large cell lymphoma and treat those patients in that particular way, and then look at what the risk profile of the CLL is. So meaning, if someone has high-risk CLL with deletion 17p, TP53 mutation, complex karyotype, unmutated genes, and if they are young and they need to go through a transplant, etc., then that is the direction where I will typically try and go to, because I know that can hopefully fix their underlying CLL and potentially this aggressive lymphoma if they are young, fit, otherwise eligible, because as allogeneic stem cell transplant would actually be curative for both the condition, lymphoma, lymphoma, as well as the CLL. If on the other hand, they have a good following treatment of their lymphoma and positive CD30, typically these patients do quite well, then I would not do anything to the underlying CLL and then just monitor these patients and see if and when they do need treatment. That's residual is large, but I don't think really that CLL treatment. I'd be comfortable, observing the patient and seeing how their disease evolves. If and when they do have disease progression, assuming that you can biopsy that lymph node or can get the molecular features from the peripheral blood, you should be able to treat these patients with whatever standard treatment that is available for their CLL.
Yes, thank you so much.
Thank you. Dr. Saswata Saha, your question, please.
Sir, is there any association between EBV infection prior with B cell lymphocytosis?
I don't think so. I don't think we've really looked at that. It's I have an answer to that. That's interesting. I mean, I think there are some data that suggests that patients who have had infections like pneumonia, etc., prior to developing MBL, there's a high risk of pneumonia and other infections, but I don't know if there are data about EBV infection in particular.
Yes, thank you, sir.
Thank you, Dr. Saha. Anybody has any other question for Dr. Samit Parikh? Yeah, please go ahead. Yes, please go ahead.
Good evening, sir.
Yeah.
Thank you, sir, for an excellent talk. And it was a very elaborative talk on MBL and CLL. I just wanted to know whether patients who are diagnosed as MBL with low counts, transforming to MBL with high counts, can they revert back to low counts, or a CLL revert back to monoclonal B lymphocytosis?
Yeah, no, that's a very good question. Thank you for asking that question. So, there is this phenomenon that has been described in other low-grade lymphomas, right? There is a classic paper from the 1980s from Dr. Sandra Horning and colleagues in NEJM, where they describe spontaneous resolution of follicular lymphoma in up to a third of patients, in about 10 years after their initial diagnosis. There are also many patients that we've seen in practice that have been described in the literature where there is spontaneous resolution of the B cell count over time. that patients were diagnosed with CLL and then their B cell count completely goes back to normal. So yes, absolutely, this phenomenon has been described in the literature. There are papers that suggest risk factors that would predict which patients might do that. It's a small subset of patients. But on an average, I don't think that happens for the vast majority. It's a very rare occurrence. The other thing that we're still sort of wrestling to find out is, is this a continuum, right? Meaning, does everyone start with a normal profile, develop low count MBL, then go to high count MBL, and then go to CLL? Or, is there a stage where patients just directly jump to high count MBL and skip this low count MBL stage completely? We don't know. We are trying to serially look for, how long it might take for someone to go from one stage to another. So again, these are all unanswered questions. But if you ask me, yes, you can certainly go from CLL to high count MBL or even to low count MBL because spontaneous resolution has been described. But it's not very common. I think in the paper that we looked at, roughly 85 to 90% individuals with low count MBL had a persistent low count MBL that was diagnosed about 8 years after. And so the vast majority will retain that small amount of clonal B cells.
Thank you.
Thank you. So anybody else, any other question for Dr. Samit Parikh? I've finished all the questions from the chat box. So, well, no other questions. Thank you so much, Dr. Samit Parikh, for throwing light on this beautiful topic of monoclonal B-cell lymphocytosis. It really helped us, and it was really knowledgeable, practice-changing. And I thank all the discussants over here to participate for this event. And thank you so much again for a wonderful question-answer session. Dr. Samit Parikh, you are really awesome. Great lecture by you. Thank you so much. I now hand over to Zydus, Mr. Sumit Madan, for the final official vote of thanks.
Thank you, Dr. Samir Parikh, for sparing your valuable time. It was a lucid presentation, and you have covered many important points, and we have many key takeaways from this wonderful presentation. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity, making us a part of this esteemed academic discussion. I also thank Dr. Amit Khurana, all the discussants and participants who have joined us for this webinar. Dr. Amit navigated the entire webinar in a highly proficient manner. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. So thank you to them as well. Thank you so much, everybody. Have a wonderful weekend.
Thank you.
Thanks a lot. Thank you so much. Thank you so much, Dr.